Hello, everyone. Let's study antibiotics. We have studied some antibiotics, such as penicillin, cephalosporins, and we also studied macrolidins, tetracyclines, and last class, we also studied some vancomycin and so on. Today, this class, we will study aminoglycosides. Aminoglycosides. The prototypical agent is streptomycin. And except streptomycin, we also use gentamicin, kanamycin, tobramycin, cizomycin, neomycin, and micronomycin, amikacin, nitimicin. These two drugs, they are new drugs in this part. The prototypical agent is streptomycin. So we have studied some antibiotics. I have told you, such as penicillin. In China, we call this 青霉素. And we studied erythromycin, means 红霉素. And we also studied cephalosporins, 头孢霉素. So, what's the meaning of streptomycin? In Chinese, we call this 链霉素. Okay, so later we will use streptomycin as the prototypical agent, explain the pharmacological effects, clinical using, and the adverse action of aminoglycosides. Pharmacokinetics means the ADME of aminoglycosides. All of aminoglycosides are poorly absorbed after oral administration, so we use aminoglycosides. The commonly using method through the injection. The concentration in the renal cortex may reach 10 to 50 times. In urine may reach 25 to 100 times of the blood level. For this reason, that means in renal cortex or urine kidney, the drug's concentration higher than other tissues, so maybe damage renal function. And later we will explain the adverse action. The major adverse action of aminoglycosides is nephrotoxicity. The reason is here, because the concentration in the renal cortex may reach 10 to 50 times. Okay, next figure is the half-life. The half-life in the lymph of external ear is 5 to 6 times as long as that in serum. Do you remember we have studied one professional term is PAE, post-antibiotic effect. So that means when the drug's concentration below in MIC, but still can kill the bacteria, we call this PAE, post-antibiotic effect. And come back this sentence. The half-life in the lymph of external ear is 5 to 6 times as long as that in serum. So maybe the drugs will damage hearing cell, so maybe induce autotoxicity. Later, we will explain the adverse action of aminoglycosides, and its adverse reaction includes autotoxicity. The reason is this reason, because longer half-life in the external ear than other tissues. Number 4, aminoglycosides, their normal half-life in serum about 2 to 3 hours. Can be increased to 24 to 48 hours in patients with significant impairment of renal function. So that means elderly patients or renal function abnormal patients, we should reduce the doses, or we should reduce the prolong the drugs course, because the longer half-life in patients with significant impairment of renal function. Okay. Aminoglycosides, the prototypical agent is streptomycin. So, at first, we use two words to explain aminoglycosides, streptomycins. The first word is narrow spectrum. Narrow spectrum means the only effect on limited groups of microorganisms. So, aminoglycoside only effect on gram-negative aerobic organisms. The first word, narrow spectrum. And the second word is bactericidal agents. We have studied what's the meaning of bactericidal. Means the can kill gram-negative aerobic organisms, such as these bacteria. They are gram-negative bacillus. For example, Escherichia, Klebsiella, Salmonella, Serratia, and Brucella. They are gram-negative microorganisms. The mechanism of its action. In the beginning of this part, we have studied we divide antibiotics into 5 parts, and these 5 parts drugs can inhibit. They in accord with their mechanism divided into 5 parts. Do you remember these 5 words? The first word is cell wall. Yes, very good, cell wall. And we studied penicillin, cephalosporins, and vancomycin inhibit cell wall synthesis. The second word is cytoplasmic membrane, and we studied polymycin inhibit cytoplasmic membrane. And the third mechanism is protein. Lots of drugs inhibit bacterial protein synthesis. And number 4, the fourth kind of drugs, the fourth mechanism is DNA or RNA. And we studied quinolone and rifampicin inhibit bacterial DNA or RNA synthesis. The last type, the last mechanism is some drugs can inhibit folic acid synthesis, regulate metabolism, anaerobic metabolism, inhibit folic acid synthesis, such as sulfonamides and TMP. Later, we will study these drugs. So, we divide the drugs into these 5 kinds, and then aminoglycosides. Aminoglycoside can inhibit protein synthesis. Inhibit protein synthesis in any of the several steps. So that's now we said bactericidal drugs can kill bacteria. And we studied some drugs such as aminoglycosides can inhibit in any steps of protein synthesis. We also studied erythromycins and chromycin and lincomycin, macrolidins. This drug also includes tetracycline. This is tetracycline, and can inhibit different targets of protein synthesis. And aminoglycoside can inhibit in any of states of protein synthesis, so more powerful. It is the bactericidal arrays. Clinical using later we will explain in streptomycin, and let's study the total mechanism, total interactions of aminoglycosides. Aminoglycosides have 3 toxicity, 1 reaction. So 4 interactions. These 4 interactions includes 3 toxicity, 1 reaction. The first toxicity is the autotoxicity. Autotoxicity and aminoglycoside use, long-term use aminoglycosides induce vestibular disturbance, so the patients lose of balance. In aminoglycoside, neomycin higher than kanamycin, higher than streptomycin, higher than gentamicin, tobromycin, and nitromycin. So these two drugs, serious ototoxicity. And some patients use the drugs 2 to 4 weeks later. They lose their balance and vestibular disturbance. Also can induce hearing losing. So about 7% of patients receiving streptomycin aminoglycoside for more than only 1 week have a measurable decreasing in hearing. The incidence of subclinical ototoxicity is 10 to 20% of patients receiving streptomycin. The simultaneous administration of high resilient diuretics will induce the risk of ototoxicity. So here, we must confirm this again. In clinic, three kinds of drugs have ototoxicity, serious ototoxicity. The first kind, just now we studied aminoglycoside. Yes, aminoglycoside, very serious ototoxicity. Just now explained. Only 7% of patients only use one week will have ototoxicity, decrease in hearing. And then the second case, we studied vancomycin. And the third one is high efficacy diuretics, furosemide. High efficacy diuretics, furosemide. These three kinds of drugs have serious, obviously ototoxicity. So we couldn't call them each other. And do you know in clinic, more than 35% deafness, and because they long-term use these three kinds of drugs, induce subclinical ototoxicity. So we should know, we must pay attention to 2 points. The first point, don't long-term use. The second one, we couldn't use them. The simultaneous administration of furosemide will induce the risk of ototoxicity. That means we couldn't administration them together. Okay, so couldn't co-administrated drugs. And first, just now, we explained the first idle section of aminoglycoside ototoxicity. And it is the chronic toxicity. Long-term use, more than 4 weeks, will have serious ototoxicity. And more than 4 weeks, will have the second chronic toxicity is the nephrotoxicity. Nephrotoxicity so induce the patient's acute renal insufficiency, renal dysfunction. And in aminoglycosides, neomycin higher than kanamycin, higher than tobromycin, higher than streptomycin. And the long-term use also induce renal failure. Aminoglycoside level must be mirrored and the drug doses adjusted. So do you remember I confirmed several times? In clinic, 3 kinds of drugs have obviously nephrotoxicity. Do you remember the 3 kinds of drugs? The first one is the first generation cephalosporins. The second case, yes, we studied vancomycin. And the third one is this one. Today we studied aminoglycoside. Aminoglycoside have serious nephrotoxicity, induce nephrotoxicity. So we said we must pay attention to 2 points. The first point, use these 3 kinds of drugs. We couldn't long-term use. And the second one, if the patient's renal function abnormal, we couldn't use these three kinds of drugs. These three kinds of drugs have serious nephrotoxicity. So these three kinds of drugs, we couldn't put them together. So couldn't co-administrate with each other. Will have serious nephrotoxicity. Thus now we studied the chronic toxicities of aminoglycoside. So in clinic, the patients use aminoglycoside. They shouldn't long-term use. And you should know the patients shouldn't long-term use more than 4 weeks. More than 4 weeks. Okay. The third toxicity is the acute toxicity. And acute toxicity means the patients maybe only use one time overdose and induce this acute toxicity. Acute toxicity is the neuromuscular junction blockade. So neuromuscular junction blockade toxicity is the acute toxicity. Only one time, but large doses at high doses and in combination with muscular relaxing drugs, resulting neuromuscular junction blockade, such as respiratory paralysis. This results from a decreased sensitivity of the postjunctional membrane to isocycline and possibly because of decreased release of transmitter. So I have a question. It is the acute toxicity, the patient's neuromuscular junction blockade. So decreased sensitivity of the postjunction membrane to isocycline and respiratory paralysis. So doctors, if we want to save the life, to save this idle section, and we can use two drugs. One is respiratory paralysis, muscle paralysis, and muscle dilation. So we can use which drug to excite? Yes, calcium. So the first drug, we can use calcium to save the life. And the second one, because isocycline reduced. So isocycline reduced, we should use which drug to increase isocycline? Do you remember? Yes, neostigmine. So once respiratory arrest occurs, calcium containing preparation and then neostigmine should be administered to save the life to treat the third toxicity, neuromuscular junction blockade. The last intersection is hypersensitivity reactions. 1% of patients use streptomycin will have allergic shock. Allergic shock may occur when streptomycin is administered. So, same with penicillin. We know 5 to 10% of patients use penicillin, cephalosporins will have allergic hypersensitivity reaction. And 1% of patients use streptomycin injection and will have allergic reaction. And the worst sequelae is allergic shock. So, same with penicillin, same with cephalosporins. The patients use aminoglycoside, especially streptomycin. The first one, we should remember, we should ask history. Yes. Have you used the streptomycin? Have you used the penicillin? Do you have allergic reaction? And then the second one, we should do the skin test. Yes, do the skin test. Though we do the skin test, few patients still have allergic shock. So we must prepare the first choice urgent to prepare the drugs to save the life. So do you remember the first choice urgent? to treat allergic shock is subcutaneous injector. Yes, very good. Adrenaline, epinephrine. So each kind of allergic reaction, we use these antibiotics. First one, ask a history. Second one, do the skin test. The third one, prepare adrenaline to save the life. And then co-administrated with glucocorticoids. Okay. Just now we studied the allergic reaction of aminoglycosides. So let's study the different properties and the clinical using of different aminoglycosides. The first one is streptomycin. It is the prototypical agent. Streptomycin used to treat plague and rabbit fever as the first choice agent. Do you know plague? This disease infected by rats, by mouse, and this one infected by rabbit. And plague. So you stay in China, do you know? In Jinzhou, we have some plague infection, infected by rats, by mouse, and the patients, plague patients, the renal function reduced hugely, and acute renal failure, and red bleeding skin rise, and you should know the patient's fever. Yes, they are plague. First choice agent is streptomycin. Brucellosis. Do you know this disease? Infected by SIPs. Infected by SIPs. And this brucellosis fever, pneumonia, is the wave fever. Oh, body temperature increase, decrease, increase, decrease. Looks like a wave. So we call this brucellosis. And infected by SIPs. And if you have this patient's wave fever, you should ask them, oh, in your house, do you keep the SIP? And some of them, they are farmer, they have SIPs, so you can diagnose brucellosis and streptomycin as the first choice agent. And other infections such as infective endocarditis should combination with penicillin. Why? Penicillin kill gram-positive and streptomycin kill gram-negative. And endocarditis, most of them, they are mixed infection. So we combination with streptomycin, combination with penicillin to treat endocarditis. And the next one is the tuberculosis. Tuberculosis, streptomycin is the oldest drug used to treat tuberculosis. And this year, we still use streptomycin to treat tuberculosis, still in the first line anti-tuberculosis agents. And number 5, prophylactic using. So to prevent bacterial endocarditis, respiratory, gastrointestinal, and urinary tract infections, or post-operative infections, we can use some streptomycin. But in fact, this year we rarely use streptomycin. And in clinic, streptomycin for this disease, plague, rabbit fever, brucellosis, and tuberculosis still as the first choice or in the first line drugs. Clinical using of streptomycin. Gentamicin used in treatment of serious infections caused by gram-negative bacillus, septicemia, osteomyelitis, meningitis, and so on. Gram-negative infections, serious gram-negative infection. Also used in Pseudomonas aeruginosa infection in combination with carbonicillin. We have studied this semi-synthetic penicillin. Endocarditis in combination with penicillin. That's now explained this in streptomycin. And gentamicin, a little different, can oral administration to prevent intestinal infections and preoperative preparation. Oral drink gentamicin and then inhibit intestinal infection. Also, topical using for treating infections occur at skin, mucosa, membrane, or eye, ear, and nose. Topical using. Okay. Next one is clindamycin. Clindamycin is too toxic. So just now explained ototoxicity, nephrotoxicity. So it has been largely superseded by less toxic, more effective agents. So rarely used. Tobramycin. Okay. This year we use tobramycin. So tobramycin has a special spectrum of activity similar to that of gentamicin, but may be more effective against the pseudomonas aeruginosa. So this year, in aminoglycoside, the most widely used drug is this one, tobramycin, 妥布霉素. Tobramycin against the Pseudomonas aeruginosa is 2 to 4-fold of gentamicin. So, burn infection always infect the Pseudomonas. So, we use the drug is aminoglycoside. In aminoglycoside, we use the drug is tobramycin. Do you know tobramycin also be local administered? So this one, have you used this one tobramycin? It is tobramycin eye drops, eye jam, eye gel. Amikacin. The major property of amikacin is that it cannot be inactivated by synthase, so drug resistance. Amikacin also has a spectrum of activity similar to that of gentamicin, but it often is reserved for causes which resistance to gentamicin and clindamycin has emerged. Okay, other aminoglycoside such as neomycin, too toxic, rarely used in clinic. So this class we only use tobramycin in clinic, and the prototypical agent is streptomycin. Okay, let's summarize this chapter. The mechanisms of aminoglycoside inhibit bacterial protein synthesis. Very easy. And then the pharmacological effects of aminoglycoside only kill gram-negative bacterial. So clinical using very easy. Gram-negative bacterial infection, such as just now I explained, such as colloquial brucellosis infection as the first choice. Adverse reaction very important. And just now I explained four adverse reaction and three toxicities, one reaction. The first toxicity is the ototoxicity, and the second toxicity is the nephrotoxicity. They are chronic toxicity. And the third one is neuromuscular junction blockade muscular toxicity. And these three toxicity. One reaction is the hypersensitivity reaction, allergic reaction. Okay. So this class we studied aminoglycosides. This class is over. See you next time.